because of the way that when we step, we tend to step more toward the outside part of the foot. So that's why the 4th and 5th TMT joints have to have more motion so that it can accommodate and allow you to sort of roll over to the medial part of your foot. And then when you go through your toe off phase of gait, you're pushing off of the medial column. So that's why that needs to be rigid. Okay. And then the midfoot is starting at the TMT joints and going back to the transverse tarsal joint. And the transverse tarsal joint is a combination of the talonavicular joint and the calcaneocuboid joint. But you'll hear people say the transverse tarsal joint, even though it's actually 2 joints. And then the hind foot is your talus and calcaneus. The anatomy varies a little bit in that not everybody has 3 phalanges in each of their toes. For the most part we do, but not everybody does. Most frequently it's the 5th that doesn't have a middle phalanx, so you just have proximal and distal and just 1 IP joint instead of 2. Some people will even have that on the 4th, but that's less common. And then not everybody has 2 sesamoid bones either. And one thing, and by far the #1 question that patients ask me on x-rays when I'm showing them their x-rays, what is that? Like it's a tumor or something. I'm not sure what's running through their mind, but I guess it does sort of stick out in that way on an x-ray, but they are quite normal. And a lot of times there's what we call a bipartite sesamoid. So when the bone is forming, it just doesn't have a full osseous bridge across the segments, and so it can look like there's a fracture. And a lot of times I think it's misdiagnosed as an acute fracture. If somebody has pain around the sesamoids, everybody wants to blame it on the bipartite sesamoid. They can be symptomatic, but usually that's not really what's causing the pain. Still be painful even if it was a regular sesamoid. Okay. And then, so this again just kind of highlights those joints that we were talking about, but it also shows, I think, in kind of a simple schematic, some of the muscles that are coming across, and we'll talk about that in a second here. So it's a little bit messy, but I think the things that are important, particularly from surgical anatomy, are the perineal tendons that run along the lateral side of the hind foot. Is that so? How do I put the
So if you want to click on this pen right
that
there,
guy?
yeah,
That's
laser.
okay. So sorry. So the lateral hind foot and ankle, right? So we've got 2 and sometimes 3 perineal tendons that run back there, and then there's what's called the peroneus tertius, which runs in front of the fibula. But some people also have what's called a peroneus quartus, which is just an accessory muscle that we don't really need. And if we run into it in surgery, we typically take it out, like an appendix or something like that, because what can happen usually, while the reason that we're operating on the perineal tendons is because they're crowded, like they're unstable, and that quartus muscle can just take up space, and so it can lead to more instability of those tendons wanting to pop out around the fibula. Anybody know what keeps the perineal tendons located behind the fibula? There's really two structures that are important to keep the tendons localized on the back of the fibula. One of them is the bone itself, right? So for stability of those perineal tendons, you would like for the back of the fibula to be concave, right? So that those tendons want to kind of rest in the back there like a dish. But we also have a ligament that holds them called the superior perineal retinaculum. So I liken it to like a seat belt, right? So it comes around the back of the ankle and it attaches right on that sort of posterolateral aspect of the fibula, and it just holds the tendons sitting in there, okay? But particularly with an inversion type injury, you can have a rupture of that superior perineal retinaculum, and that can lead to instability of the tendons, where the tendons can either frankly dislocate and be popped out around the side of the fibula, and they may reduce or they may stay out. That can be an injury that a lot of people come in with sort of a delayed presentation because they know something's wrong, but they can't really tell what it is. And everybody figures if they can move their ankle, then nothing's really broken and it should get better. But those types of injuries rarely get better on their own. Sometimes they'll avulse a little piece of bone where the retinaculum attaches. Sometimes they'll just sort of rupture right through it. But those rarely get better on their own. We can try, to cast them if we do catch it acutely, but more commonly we see those injuries come in a delayed fashion because, again, people don't really realize how bad it is, and they just feel instability of the ankle. They can feel, something's popping around in there, and they don't really know what it is, but it's actually the tendons themselves popping around the bone. And the problem with that is you lose function of the tendons because you no longer have the same vector. The tendons aren't pulling in the right direction. They're not going through the right course anymore, so you lose strength. But also, as the tendons keep popping around the bone, they can actually lead to abrasion and rupture of the tendons. So that is something that we frequently need to fix with surgery. So those guys are important. We see a lot less pathology with the extensor tendons of the foot than with the flexor tendons in general, with the exception being the tibialis anterior tendon. Not infrequently, you can get tendonitis of that. If somebody hasn't been, using their foot a lot, and then they go and do a big hike or something like that, lifting, up and then down. By the time they get back to Tennessee, they're pretty sore. But you can also get tendinosis in the tibialis anterior tendon, which I don't know if you guys have run into tendinosis yet, but you can get it essentially anywhere in the body: tennis elbow, shoulder pathology, as well as more frequently the Achilles tendon or the posterior tibial tendon. But the tibialis anterior tendon will also get some tendinosis. And then the flexor tendons, we see a lot of pathology with the Achilles tendon, either with tendinosis, which is sort of a chronic degenerative problem with the tendon, but obviously also ruptures of the Achilles tendon. The other tendons tend to not rupture so much as they develop split tears. And so the tendon structure itself is what we call viscoelastic, which essentially is like silly putty, right? Meaning that its strength is dictated by how quickly it has the deforming force put on it. So if you stretch silly putty slowly, do they still have silly putty? Mm-hmm. They have, what's the stuff my kids have? It's some sort of like thinking putty or something like that. It's like shiny silly putty. Anyway, if you pull it slowly or you stretch the tendon slowly, it will stretch pretty far. But if you stretch it really quickly, it just snaps. The Achilles tendon is just like that. So we'll see Achilles ruptures all winter long in ski boots, which you would, think is not something that would happen very frequently, but that's a perfect example of how that happens. It doesn't have to move very far, just has to have that load put on it quickly. And then the posterior tibial tendon, runs basically right underneath the medial malleolus and is a big problem for people who have flat feet. So, a lot of times there's congenital flat feet where, the structure of the bones when everything forms when you're a child sets you up to having, a low arch and pronated foot, and then you can develop a valgus hindfoot, and then that puts a lot of stress on those medial structures, namely what's called the spring ligament and the posterior tibial tendon, and then eventually the deltoid ligament as well. And then dancers in particular, but in theory, anybody could get it, but dancers tend to get it more frequently, or if you're asked on a test somewhere about FHL tendonitis, the flexor hallucis longus tendon. It runs, posteriorly right against the back of the tibia, and then runs just medial to the talus, right through this little groove here, and then all the way out to the toe. Well, obviously, if you're a dancer and you're putting a lot of time on your toes, you're really working that FHL tendon more than any normal person is supposed to, and so you can develop tendonitis or even tendinosis and tears of the FHL tendon. But the classic finding with that is that somebody has pain even in the back of the ankle with resisted flexion of the hallux. And what is the FHL tendon? What is its function? What does it do? It's a flexor, but it flexes what? And specifically, think about, and in general in orthopedics, think about with muscles and function, think about where it's starting and where it's attaching to decide what it is that it does. So it attaches at the distal phalanx, right? So it's going to bend both the IP joint and the MTP joint. But because it's crossing the ankle, it's also a flexor of the ankle. Not a very strong one, but it is, okay? So that's one of the structures that allows people with an Achilles rupture to think, oh, it's okay, it's not broken, I can move my ankle, And so sometimes people will come in a delayed presentation with an with an Achilles rupture as well, because yeah, it's sort of hurt, it's feeling better, you can move your ankle, you can push it down, but you could not lift yourself up, without assistance with that. So the FHL, and then what are the other flexors that run back there? We already talked about the peroneal tendons. There's 2, sometimes 3 of those. The Achilles tendon. Somebody name one. There are 2 more flexor tendons. We already talked about one of them. Flexor digitorum longus, we haven't talked about yet, and the posterior tibial tendon. Okay, so all of those allow you to still plantar flex your ankle even if you don't have the Achilles, but the Achilles is what gives you most of your strength. You don't really see much pathology with the flexor digitorum longus, the FDL tendon. In fact, both the FHL and the FDL tendon are tendons that we can kind of sacrifice, meaning, if we say somebody has Achilles tendinosis, chronic Achilles tendinosis, and we have to do surgery to sort of remove the tendinosis, if we have to take too much of it, then we need to put some support back in there. And so a lot of times what we'll do is actually detach the FHL tendon from its insertion, or you can just sort of take it from the back of the ankle, and then we'll reattach it to the calcaneus. And so it will function in the same manner as the Achilles tendon, okay? Likewise, the FDL tendon is sacrificed frequently when we are doing a transfer for somebody who's got a flat foot and posterior tibial tendinosis. So again, if we have to debride a lot of the posterior tibial tendon, or sometimes we have to sacrifice the whole thing if it's just completely shot. And then what we'd do is detach the FDL tendon down here at what is called the knot of Henry, and attach it into the navicular directly. Okay, so the anatomy, again, is important for function because you have to think about where it's starting and where it's inserting, and you can kind of figure everything out. It takes some time to learn the anatomy. It hasn't changed in a while, the anatomy. Okay, questions about all that? Anybody online? We get like messages or something like that?
They can.
Oh, okay.
Look at chat. I keep it on.
Oh, okay. All right.
It's popped up.
All right, good. Okay. All right, so that's muscles and bones. Let's talk about the feelings from the foot. It's very sensitive. How many nerves do we have going to the foot? Major peripheral nerves. Anybody? Start with an easy one. Mm-hmm. We have 2 perineals. So for everybody online, that was the deep perineal and superficial perineal, saphenous, sural, tibial nerve. They're all important with the exception of the sural nerve, in that the sural nerve really just gives you sensory function at the foot, and so that is one that can get sacrificed. And so with certain hand injuries, if there's like a digital nerve injury or even a more important proximal nerve, a lot of times the sural nerve is what gets used as a graft. So they'll take the sural nerve from the ankle and transfer it somewhere else. But the tibial nerve, I would say, generally is the most important because it gives you sensation to what part of the foot? Plantar surface of the foot, right? So the plantar surface is most important because that's, again, going to let you know when you're stepping on something that's you're not supposed to be stepping on. It helps you with your balance. It helps you with your proprioception. So we really try to preserve that. No matter what, we really don't sacrifice the tibial nerve. The other nerves, you can, if somebody were to develop say a symptomatic neuroma, like they had an injury, something, dropped on the top of their foot and they've developed a neuroma on their superficial perineal nerve on the top of the foot. Ideally, that just goes away. The pain from the neuroma or the neuritis will typically dissipate, but sometimes it doesn't. And if you need to, we can actually just resect the superficial perineal nerve and then bury it either into the bone, typically the tibia, or into the musculature up there, so that as that stump of the nerve, generates a neuroma, it won't be painful. So that's going to leave you with loss of sensation to the greater part of the top of your foot, the dorsum of the foot, but you'll still have some sensation from the other nerves. The sural nerve is notorious for having that, for developing a neuritis or a neuroma. And you can see it with the sural nerve or the superficial perineal nerve with inversion ankle injuries. It can be as simple as just rolled your ankle over and it stretched everything too far, including the nerves. And so some people will feel like they've got, paresthesias, tingling, or they've got numbness on the side of their foot or on the top of their foot from those injuries. And the sural nerve, again, is kind of notorious for doing that. It's really sensitive. It's really superficial, and for one reason or another, is more sensitive to developing those types of injuries. Okay. With the tibial nerve, there are important branches of the tibial nerve in the foot and ankle clinic, in that you can develop pathology with those branches of the nerve. So some people who have heel pain, the vast majority of heel pain is coming from the plantar fascia. But you can have what's called Baxter's nerve entrapment, which is where the first branch of the lateral plantar nerve is getting pinched by the fascia or some other structure in the hindfoot. So tibial nerve runs along the back, posterior medial aspect of the ankle, and then the first branch that comes off is called the calcaneal branch. So on the diagram, that's kind of showing this orange area, so it gives you kind of the feeling to the heel, and then the lateral branch comes off next, and then the medial branch. And it's that lateral branch that has what's called Baxter's nerve. And so you get entrapment of that, and you can have plantar heel pain that can sort of masquerade as plantar fasciitis. So people who aren't getting better with their plantar fascia treatment, one thing that we always have to consider is whether they have entrapment of Baxter's nerve. Pretty uncommon, but it does happen. All right. Questions about the nerves?
You have to go in there and release that.
Yeah, so sometimes, yeah, if we get to the point where we've sort of, usually it's a diagnosis of exclusion, I would say. I mean, on rare occasions, you can get an MRI and somebody's got like a ganglion or something like that, some sort of a mass that's in there and, is physically putting pressure on the nerve. You rarely see pathology of the nerve itself. More frequently, what you see is sort of the effects of having that nerve be degenerative, in that you can see denervation changes to the muscles in the foot, and so that can be enough to sort of cause the pain in there. But again, you go in there in surgery, and typically by the time you're releasing Baxter's nerve, you've probably already done something for the plantar fascia, whether it's an injection or months of physical therapy or what have you. And then just go in and release the fascia around it. And it's not a home run surgery, but it's one of those procedures that by the time you're getting there, somebody's pretty exhausted with having that pain.
Sure.
The other thing that can cause pain to the bottom of the foot is tarsal tunnel syndrome, and that occurs because the tibial nerve is running through that posterior medial aspect of the ankle, and there's a flexor retinaculum on that side, and not nearly as frequently as with the carpal tunnel, but you can get the same sort of problem where for one reason or another there's too much pressure on the nerve in the tarsal tunnel because it's an enclosed space. And so sometimes you have to go in and just release that flexor retinaculum, sort of let the pressure off of the tibial nerve. And that usually manifests, tarsal tunnel syndrome usually manifests with pain or numbness, paresthesias that's localized just to the bottom of the foot. Somebody that has, dysesthesias to the plantar surface of the foot and the dorsum of the foot, it's probably not tarsal tunnel syndrome. And it's probably not, because that's multiple nerve distributions, it's probably not just, there's not just one simple solution to that. It's realistically, it's probably peripheral neuropathy. Or it could be something that's coming from more proximal, say, impingement in the lumbar spine or something like that. But even with that, again, that's usually more focused. Like people say, it is right here in this little pink distribution on my foot that I can't feel things, or that's where I feel the pain. And a lot of times people will come in, and they've got markers drawn with different colors and X's and circles and stuff like that. And sometimes that can be helpful, other times not so much. But peripheral neuropathy, we don't see it a ton here because we don't have a lot of diabetes, and that's the most common reason to develop peripheral neuropathy, but it is out there. So good. Other questions about nerves? Okay. Let's see what's next. Okay, so I think that one of the important things for talking about the foot and ankle is, and anything in orthopedics, but I think it's a little bit more complex in the foot and ankle, is just the terminology for motion and mechanics. So varus and valgus, you'll run into that in the knee if you haven't already. But I don't have anybody know any good mnemonics for remembering which one's varus and which one's valgus? I don't really have one, but something about an L maybe.
Yeah,
Does valgus somehow? But how would you remember which way it goes?
That's what, the L is lateral. Like you're
Yeah,
pushing on the
okay.
lateral
It's like that. So the
And the
foot's
varus
going
usually
more
push with your
lateral.
right hand.
Okay.
time.
Okay, all right. Yeah, in the foot and ankle, they both can be pathologic. They can lead to problems, but in general, you're going to see a lot more hindfoot valgus than you are varus. And in general, in the world of orthopedics, things are better accommodated with valgus than they are with varus. Whether it's, how a fracture is reduced or how the patient's natural anatomy is formed. Valgus is more forgiving. So we talked a little bit about pathology that people get with valgus in the flat foot deformity. What sort of problems do you think people with hindfoot varus would have? What is somebody with hindfoot varus going to complain of when they come into clinic? What sort of issues do they have? If you're walking like this all of the time because of the structure of your foot, what sort of problems are you going to have?
Yeah.
Right. Typically lateral sided pain. Certainly can get tendonitis, typically with the peroneal tendons, but most frequently they're going to complain of instability because they're already sort of tipped over like this. Every step they take, it's that much easier for them to just roll their ankle over. So they will come in with a decade's history of lots of ankle sprains and rolling ankle and can't figure out why that is. And a lot of times it's just, it's just congenital. It's just how your bones were formed. Sometimes it is neuromuscular in that we don't see it very much anymore, and hopefully we don't see it more, but polio, left a lot of people with varus hind feet just because of the imbalance that forms with the muscles, and that you get more pull on the flexors on the medial side and not enough balance of the peroneal tendons on the lateral side, and so they end up sort of in varus. The treatment for varus and valgus hind feet is kind of a whole nother talk. But in general, what we want to do is try to rebalance things. And so sometimes that means actually sort of shifting the bones. And typically we do that through an osteotomy of the calcaneus, where we actually just cut through the calcaneus. And if they're varus, then we need to shift the heel bone laterally and then put some screws in there and let it heal, and that will help to get them so that now that calcaneus is not on the medial side of the long axis of the tibia, but neutral or maybe even just a little bit valgus to balance them out. But typically we're also having to do something with the peroneal tendons and something like that because they've had lots of sprains and issues with that, tears of the peroneal tendons. And then we'll do a lateral ligament reconstruction because almost always their ligaments are shot too. Okay. And then at the ankle, as it comes up, that's dorsiflexion, and as it goes down, it's plantar flexion, right? So not extension at the ankle. They're both flexion, but when it's dorsiflexion, it's plantar flexion. With the toes, you'll hear it sort of both ways. You will hear flexion at the toes and extension at the toes, but you'll also hear plantar flexion and dorsiflexion at the toes. And it's just sort of how we describe the sagittal plane motion. Okay, internal rotation, that's pretty obvious. Okay, that sort of happens about the tibial axis, and then inversion, eversion, and then pronation and supination. Well, I'll get into it a little bit. I don't want to get in the weeds with all of this, but pronation and supination is a little bit more. It's sort of a three-plane motion, right? It's not just isolated to one joint, but this sort of shows your typical motion for the tibio-talar joint. Most people have about 15 to 20 degrees of dorsiflexion at the ankle and should have about 45 degrees dorsiflexion. Dorsiflexion is more important typically for normal function, in that if you can't dorsiflex the ankle up, your gait is going to be more altered. And if you can't even get past neutral, then we're probably having to do some sort of procedure to get you more dorsiflexion. People can get by without having to plantar flex a whole lot. You can kind of push off and fake it a little bit, but it's hard to fake dorsiflexion. So the accommodation that people who don't have dorsiflexion have is that they'll want to cheat and sort of externally rotate as they walk, because then as they roll through their gait phase, they sort of roll off at an angle instead of having to go directly over the toes in that direction, which they can't become. Okay, talked about internal, external rotation. All right, so the eversion and inversion is happening at the transverse tarsal joint, okay, and the subtalar joint. And you can't have inversion and eversion without motion in both of them. If you were to fuse the transverse tarsal joint, you would essentially have no motion at the subtalar joint, and likewise, if you fuse the subtalar joint, you have much less motion at the transverse tarsal joint as well. And that is most important with supination and pronation, and that's because we're talking about, eversion and dorsiflexion as well. Okay. All right. This is kind of a busy slide. You guys will have copies of this, but this just sort of shows all of the muscles that are involved with those motions when you put it all together. Okay. I think that's probably enough of the anatomy talk. I don't think that we should get too much into physical exam unless you guys have something specific that you want to talk about with physical exam today, or more about the anatomy. Quick physical exam. If somebody is injured on the field, what are you guys gonna check first? Like, oh, my ankle hurts. They're rolling around, laying on the 50-yard line. What are you gonna do? Sure, right. So how are you gonna rule out a fracture? Yeah, right. Like, okay, where does it hurt? Okay, is it is it in your shin, right? First of all, you'll probably see that if that's, an acute injury. That one tends to look a little wonky, but not always, right? You can have a non-displaced tibial fracture. But essentially, it's the malleoli, right? You want to start there, okay? Medial and lateral malleolus, if they're tender on the bone, probably a fracture, or that's at least got to be at the top of your differential diagnosis. Other important bones to palpate: the talus, navicular, and the calcaneus, right? Midfoot, you can kind of get into the weeds with that. And, those Lisfranc injuries that we talked about at the beginning, very, very commonly missed. Like 20 to 30% of those injuries are missed in the ER when they have x-rays. They don't always have a fracture with it. And even when they do have a fracture, a lot of times they're fairly subtle. And so you might not, if you're not used to looking at a lot of foot x-rays, you might not notice it. And they rarely do weight-bearing x-rays. And so you might not notice some subtle instability in there. But back to our kid that's laying on the field. So malleoli, talus, navicular, calcaneus, and they're probably going to kind of hurt everywhere, right? But I think if they have bony tenderness, then you're probably not going to have them put weight on it. If they don't have bony tenderness, then you can kind of see, can you put weight on it, right? Stop me if I'm saying something wrong. And then you can kind of get them over to the tent or whatever you got to do to do sort of a more detailed exam. And then that's where you're going to be palpating lateral ligaments, medial ligaments, checking the flexors. extensors and stuff like that. Eventually, you'll look for an effusion, right? And what's the difference between an effusion and edema? Right. So which one's in the joint? The effusion is in the joint, right? It's like a water balloon. And it can be a little bit difficult to tell the difference between the two depending on where you would have edema, but generally, the edema is going to be through the whole ankle. It might be more on the lateral side, and ironically, you might see more edema with a lateral sprain than with a lateral malleolus fracture. That's not uncommon. Like, somebody will blow up like they've got a golf ball or a lime underneath their ankle when they've got a lateral ligament sprain, but the lateral malleolus fractures maybe won't swell all that much, at least right away. Good. Crepitus, anybody know what crepitus is? All right, it's like Rice Krispies when they move their joint. That's usually a bad sign. Most of the time, crepitus in the ankle is a tendon issue. Like if somebody has chronically, feels like they've got cracking or popping in their ankle, it's usually not because of something that's in the joint, but because of tendons that are kind of snapping over each other, be it the peroneal tendons, peroneus longus and brevis snapping over each other, or the extensor tendons. But if it's painful crepitus, you have to worry about something like a loose body in the joint, or some sort of fracture, like an osteochondral injury to the talus. Okay, I think we should cut it off there.
I do have a question.
Okay, yes.
So, like, kind of off of the inflammation aspect of it, when you're doing an eval on somebody and say they have like posterior ankle pain, how can you tell the difference between like the retrocalcaneal bursitis and like Achilles tendonitis?
Yeah.
Because it can kind of mimic the same. All the structures are kind of similar.
Yeah. Well, so the question is, how do you tell the difference between retrocalcaneal bursitis and Achilles tendonitis or tendinosis? A lot of times they're going to have both. Is one way to start with that. What happens? You can certainly palpate the retrocalcaneal bursa is in front of the Achilles. If they just have retrocalcaneal bursitis, they're probably not going to have any pain just as you poke to the back of the Achilles tendon. But usually they're going to have pain in both because they've got both of them. And it's pretty uncommon to just have retrocalcaneal bursitis and not also have something going on with the Achilles tendon. But you just sort of feel in the front of it, right? Like that's the retrocalcaneal bursa, the space right between the Achilles and the calcaneus. And that's your Achilles tendon. Yeah. People who have chronic Achilles tendinosis will typically have thickening, or what we call fusiform thickening of the Achilles tendon, where you sort of start proximally or distally on it and sort of squeeze down. And when you get to the spot that hurts, it's like there's a marble stuck inside the tendon, so it's in that one little area. It's actually